Hi everyone, good evening. My name is Adi. I'm the webinar lead at Mind the Bleep. And welcome to the sixth and second last session in our geriatric series. We're going to be talking about acute presentations in older adults, which is a really important topic for anyone working in acute medicine, geriatric medicine, or just general internal medicine. I'm joined today by one of my good colleagues from work, Dr. Gangadharan, who is currently a trust grade IMT at Norfolk Park, having just rotated through geriatrics. And he's going to be talking to us about common things not to miss and kind of how to approach workup of common issues in this population. So please pop any questions into the chat as we go along. And otherwise, I'll hand over to you, Gopi. Please let me know if there's any issues. Otherwise, yeah, hope everyone enjoys the talk.
Thanks, Aditya, for the introduction. I thought we were good friends by now. I thought we evolved from colleagues to good friends, but that's okay. Like Adi mentioned, I've just rotated from geriatrics, and geries as a specialty is quite interesting because I think there's a lot of, like the presentation says, there's a lot of signal in the noise, and making very fast, quick decisions at times can be challenging if you don't understand the underlying pathology or the physiology in this case. If let me see, just a bit of yeah, there you go. Fine. So in this session, we'll be the learning objectives at the end of the session. You should be able to differentiate and manage things like delirium. How is it different from dementia? How is it different from depression in the acute setting? Right. Sepsis 6 in the first hour in sepsis management. I'm sure we are all been told to death about it, but again, it remains one of the highest mortality issues in the elderly. Faults versus syncope. How are we working them up and managing them safely? Again, a very common presentation in the elderly. Um, your atypical findings in ACS and stroke, especially obviously in the elderly patients, and a lot of polypharmacy and the risk associated with multiple medications, right? And then a smaller conversations or walkthroughs between AKI and dehydration, and the importance of using CFS and use scoring to guide our escalation and managing or placing ceiling of care in these patients, right? Why do older patients present differently? I know there's a couple of things mentioned on the slide here, but can we just put some what your thoughts are in the chat, if that's okay? Some quick ones, and Aditya, my colleague, would tell me what's going on in the chat.
My friend, I will let you know as soon as we get any answers.
Radio silence?
There's normally a bit of a lag between Restream and YouTube, so it might just take a minute to feedback through. Nothing as of yet, but from my own experience, I guess one of the things that we do often see is it's difficult to get an accurate history sometimes from these patients, particularly if they're acutely unwell. As you're going to talk about, delirium is a common issue. So getting an accurate history and kind of actually understanding what's going on with this patient can be quite challenging. At least that's been my experience thus far.
Yeah, absolutely. I think knowing what their baseline is, if someone's baseline is that they are confused most of the times, and them presenting the same way, there's usually not a lot for us to do. But knowing what their baseline is and getting a very good collateral, like Adi mentioned, from their caregivers, from the nursing home, or from the family members, because they are the best people to tell you what's off with them. And those are usually very important. So to begin with, their physiology is you have a lot of noise, right? A baseline noise per se. They have cognitive impairment. They have a lot of chronic diseases like diabetes, which gives them sensory losses. They have a lot of multi-morbidity burden to deal with. Their physiology is blunted. They don't respond the same way a healthy, normal adult would in cases of shock or chest pain, or like we will talk about stroke as well. A lot of these patients also have a lot of medications that can blunt even if they have these physiology, right? So things like steroids can blunt a lot of your inflammatory responses. A lot of anticoagulants as well can give you a very mixed picture. Your beta blockers will blunt all your tachycardic responses as well, right? Some of the clues that we tend to see in elderly patients are the atypical stuff. So some atypical clues would be like falls, new onset confusion, mobility in someone, reduced mobility in someone who was actually going about really well, not eating as much, not responding as much. All are kind of like a typical feature that you see. Atypical typical features or typical atypical features per se, right? Usually, I want to walk you through a very rapid what we all have been taught in medical school, which is your A to E, but with a frailty lens, right? So your airway and breathing, like we always talk about a lot of our people here, is the are they hyperventilating? Is there a silent aspiration risk? So knowing what their swallow is like is very important. Again, something from a very good collateral history. What are their orthostatic vitals? So things like how do their blood pressure and heart rate change with supine and standing positions? Hidden shock, again, blunted physiology in a lot of these patients. They don't present in a typical way, so being very aware of that would help a lot. In terms of so cognition screens, again, I've put a few slides on here. We routinely use something known as a 480 screen. We also, for other ones that we tend to use, are AMT 4 and 10. Again, I'll quickly talk through them in the next slides. The exposure areas, pain, pressure areas, catheter. If they have a catheter, is it a long-term catheter? Why is there a long-term catheter? When was the last time it was changed? All of these things are very important. Meds list. What are the routine meds? That is the most important point here. Again, we will talk about polypharmacy moving forward. Pressure areas as well, because these can pressure areas on the sides of the legs, especially your knees, your ankles, yeah, or the sacrum, the obvious areas. But if these were people who have carers and being taken care of, it usually raises a safeguarding issue, right? So these are very important to know. Pain as well, because you will have patients who would have had a fall but not present in a typical hip fracture way, right? We've routinely seen, even Adi can obviously say as well, we see patients who had a fall a month ago or something coming with worsening pain that's not getting better with painkillers, and we see that, usually on a CT scan, that there's a missed hip fracture, which is very commonly seen. Very important to take a CFS score as well at this stage, and I have put on very so this is the Rockwood frailty scale, very helpful, specifically in understanding what the basic uh, functioning baseline is, right? Because when we talk about frailty, your frailty medically, because people use it in a layman's term, it's very important to get this across to the patient and to the next of kin or the caregiver, right? It's the inability of a person to go back to that functioning baseline after a period of acute illness, right? So for you and me, healthy people, if this is our baseline and we get unwell, the baseline goes down. So you began here and the baseline goes down when you're unwell, and then it slowly picks up once we recover, right? And we are back to our baseline. In older frail people, what happens is that it goes down, and when they recover, it's not usually back to where they are, and this is their new baseline. And successive illnesses tends to get their baseline poorer and poorer. Not all frail people are old, and not all old people are frail, right? And that's a very important thing to remember in these things. Delirium versus dementia versus depression, right? It's a very common thing we come across. Um, Again, like the slides have mentioned, delirium tends to be something that is an acute presentation. Very commonly, there's a trigger: infection, pain, constipation or retention. Medications like your opiates can make you quite delirious. It's characterized by a fluctuating attention and awareness of your surroundings, right? Which we don't see in dementia, for example. Dementia would have a chronic progressive decline per se, but attention is preserved very early on in the disease, right? Depression, again, a loss of very low mood, loss of interest in the usual things that they used to do, very slow moving movement, um, can mimic your dementia scale, but the onset is quite small, and also there's a possible trigger, right? Like maybe they lost a loved one, maybe the circumstances changed in their lives, things like that. So where there's a very noticeable trigger, and the timeline tends to be quite small as well. In all of these cases, we do your usual workup, right? So like 480 that I mentioned, which I think should be in the next slide here, is something we routinely use in an acute setting on first assessment. So part of 480 is your 4AMT, which again I can show you on the next slide. So the first instance, we talk about your alertness. How is the patient? Are they holding attention? Are they verbalizing? Are they able to maintain eye contact? Are they verbalizing with you appropriately? Anything beyond this would be clearly abnormal, which is for 4, right? In so the first three is something you would speak with the patient in the first instance. 4 is where, like Adi mentioned, collateral history comes into play here. You need to be asking the people that they know, like, is there an acute change in their behavior? And in terms of how would you go about asking about hallucinations or paranoia? How do you go about asking it? Because it's not something, sometimes or most times your patients would tell you something very odd that would catch your attention, but what are some specific questions that you could ask? um, Again, I'll ask my colleague Adi to see if there's uh, anything on the chat.
Nothing as of yet, but there is a response to the previous question about kind of difficulties in these patients. Someone has correctly said they have multiple comorbidities rather than a single system being affected. So difficult to narrow down the specific reason for why they've come in with the current diagnosis.
Yeah. What do you think, Adi? Like, what are some specific things you could ask in this for teasing out paranoia hallucination? What are some key things we could ask?
So I guess it's, if there's anything in what they're saying that suggests that there is an element of paranoia, it's exploring kind of what their perception of that is, and not, I mean, for want of a better word, kind of trying to not ridicule them and just kind of working with the patient to understand and kind of create a structure for what their thought process is.
Yeah.
I guess it's also useful to see if this is acute or chronic in the sense of, if it's more consistent with delirium, this has just happened since, say, they've come into the hospital versus it's something that was happening at home.
Yeah.
We had a patient who on my ward recently who was convinced that there was some sort of box with a camera in it that was following her around from home into the hospital. So that to me suggested more of a chronic etiology as opposed to a acute etiology.
Yeah, yeah, absolutely. I think one of the key things what Adi mentioned that's really important is trying not to convince that these patients are wrong about their paranoia, right? You kind of have to work with them. So I would always ask an open question like, what do you think is wrong that's going on here? Right? And just from their answers, you would pretty much know there's an element of paranoia going on. Or hallucinations. Are you seeing anything strange here? Do you feel like anything's crawling over your body, especially in like alcohol withdrawals and things like that, right? Are you hearing anything? Is someone telling you things? Someone asking you to do things? So things like that will tease out that answer quite well. And working with the patient helps to go establish a very strong patient doctor relationship, which I think a lot of us tend to, because of the nature of the job, we tend to kind of overlook sometimes. Again,
Just very quickly, someone said something that kind of ties in very nicely to what you just said. A very open-ended question is that, just asking, is there anything bothering you or anything on your mind?
yeah,
As you were just talking about kind of with, building that relationship and the rapport with the patients, that kind of open questioning is very, very good in terms of allowing you to create that relationship where they feel like they can confide in you.
yeah, yeah, absolutely. Just going into the whole 480 that I was mentioning. So we have always been told about the AMT 4 or AMT 10, right? AMT4 seems to be actually give you the same amount of statistical really correlation as much as you would use an AMT10. The reason being AMT10, when you have that many questions, people tend to use it incorrectly in practice, like I've put it up here, and infrequently as well. So AMT4, it's nice and short and gives you kind of captures that right amount of you're trying to essentially quantify mental impairment in elderly patients, right? So, always go for AMT4 over AMT10 if you're crunch for time. Quick case that we can talk about: 78-year-old lady presents to you after a course of treatment in the community for a UTI. Now she's presenting with her caregiver saying that she's not herself, and the 480 says she's 6. Right. Two questions. One, in broadly speaking, what are some very likely precipitants in these patients? First, what do you think this is? Obviously, from the kind of presentation that we're having.
We'll just give it a minute again.
Yeah. Quick question, Adi. Are we running slow, fast?
No, I think we're all good. We're about 1/3 of the way through our allocated time, but obviously no stress either way.
Just wanted to ask again, what's the most obvious thing that's going on here?
I can, I guess, start it whilst we wait maybe for some more people to give an opinion in the chat. But I guess someone who's not herself after antibiotics, the concern would be, is this just a non-resolved UTI, antibiotic resistance? Is this kind of persistent? And do we need to think again about what antibiotics we're giving?
Yeah, absolutely. Also, like, again, in this case, we're kind of dealing with delirium per se, right? Again, I'm sure I can appreciate the question line isn't that descriptive. And like Adi mentioned, the patients already had a UTI course for the UTI, and it's not resolved. Just kind of going back from that picture, what other likely presentations or precipitants are there in this patient? So you have UTI. What's a very common thing we need to kind of make sure this that we don't miss in such patients, right?
We'll just give it a few seconds to disseminate into the YouTube stream. I think it's about 45 seconds behind. So it might just be a little bit of a lag. Nothing as of yet.
So some likely precipitants in this case, if obviously with a UTI, would be is just patient retention, right? Again, we would need to do a med review. We need to also look at, is the patient constipated? Again, a likely precipitant in this case that can cause the delirium and also precipitate a UTI as well. Any other sources of infection? Unfortunately, patients can come with one or two sources of infection, right? Can be pneumonia as well. And what are your first reactions in a patient like this? 78-year-old, not herself, clearly has a source of infection. What are the first reactions we can take?
Again, we'll give it a second, but yeah, someone's correctly suggested that one of the potential precipitants is this is consistent with delirium on a background of UTI, which, yeah, I mean, that's broadly where we are. I can give one first action, which I think is generally what anyone should do in anyone who's acutely unwell, is, do your A2E assessment and get a basic set of observations, make sure that there's nothing kind of life-threatening, just to make sure that you have stability, and then you can buy yourself some time to kind of think about what's going on a slightly deeper basis. So I've taken the easy answer, but if anyone has any other thoughts in the chat as to kind of further initial actions that you'll take, please do pop them in. We'll just give them a few seconds.
Yeah. And I'll just build on what you've said as well. I think a lot of the times I find challenging is the noise, right? When someone like this comes, and I think just doing your ATV and basic set of vitals gives you a lot of time actually to kind of think, right? Is the patient very unwell? Your ATV would give you that kind of information. What are their glucose? What's their SATs? Do they need oxygen requirement? All of these things. And while you're sorting these out, you get a better picture about what the ongoing issue is, right? So again, like Adi was mentioning, collateral once you have once you stabilize this patient and once you're digging it out, collateral is a very important thing that gives you a very nice picture as to what's going on. So like Adi mentioned, he's going to do an E2E, he's going to check the glucose, he's going to check all of those things. We spoke about precipitants. So we're going searching for a source of infection, could be a chest. In this case, it's a UTI. We look at what the precipitants are, could be retention, could be constipation, right? So we found the source. What are like some of the other things you could do?
So a couple more comments in the chat. One of the people in there has said that firstly, in terms of precipitants, dehydration and AKI certainly would exacerbate this. And in terms of kind of next actions, someone suggested to look at what medication they're on,
Yeah.
which makes a lot of sense. And someone else has suggested, it's the same two people who are doing a very great job in terms of giving us all our answers. But the other person has suggested getting bloods, doing a urine culture, and getting a collateral history are all good initial steps.
Yeah, brilliant, right? So med review, absolutely. So anticholinergics very commonly cause your retentions and things like that, right? Opioids, so codeine, things like this, cocodamol that usually patients use can constipate them quite a lot. So reviewing the medication is the right way to go. Stopping them is the right way to go, right? Again, someone mentioned about your basic things, which are like taking your basic set of bloods. If you're is a concern for sepsis, we think about following the sepsis 6 and things like that. There's also a key thing about using urine dip in elderly patients, right? In this case, with the clinical context and stuff, urine dip makes sense, and also going with the findings. But the advice is from the Royal Societies and NICE guidelines is that you doing a urine dip on a patient that does not come with features of a lower urinary tract infection or urinary tract infections isn't really advised, because you will find something. You will find protein leak, you will find some amount of red blood cells, you will find some white blood cells. But there isn't if there isn't a clinical context to go with, we don't usually start an empirical treatment for that. Okay, so in this case it makes a lot of sense, right? Urine dip, urine culture, take your bloods, brilliant, and we go ahead with that. Okay, moving on to the next one. So again, this ties in nicely to the whole sepsis in the frail patient. One thing you should always know in elderly patient, atypical is typical, right? You would have patients present with anorexia, falls, confusion, all of which will precede like fever per se that you would commonly see in your normal healthy patients, right? Again, in these cases, for obvious reasons, time is critical. You take your cultures, you give your antibiotics as per the local policy, targeted fluids. Now, fluids are a bit tricky, right? Because any guideline that we see says, give them 500 or 250 ml of bolus, which in most cases, if it's a septic infection, a septic shock precipitating a hypertension episode, sure, great, go ahead, right? But if this is a cardiogenic shock, that doesn't really make sense, right? Because you're going to make them really sick. What's a very easy thing to do to kind of assess if this is a fluid deprived patient, on during assessments? What are some things that you can do that will inform you whether you should be policing these patients?
We'll give it a quick stack. But yeah, just to kind of add to that, certainly in these elderly patients, the slower boluses and the much smaller boluses are really important. Even 250 ml given straight into a vein can sometimes tip someone when they're in a very fragile state with regards to their
Yeah.
fluid status.
Absolutely. I think Adi and I have had a fair share of issues where I think guidelines are meant to just mostly be guidelines. I think you have to let your clinical picture drive most of your decisions. So, people will tell, let's give them boluses in a patient with shock, but you have to see why is this patient in shock in the first instance, right? Which is what I'm looking at the chat for. What are some key things during your assessment that will give you more evidence to whether you should be policing such patients? Uh,
Have you got access to the chat? Hopefully, it should come up on your restream as well. But if not, I'm also keeping an eye on it, so no stress either way.
yeah, I don't want you to feel left out, my dear colleague.
Hmm.
Uh, I don't. Is it the private chat? This thing? Or sorry. Oh yeah, found it. Found it.
Yeah, yeah. But yeah, don't worry, I can moderate that. Let's see if our two very keen watchers are able to give us some more really good insights into how to manage this and investigate.
Hmm.
Nothing just yet. Um, I mean, I can give a quick opinion, I guess. Common things are obviously OBS. So, if someone is hypotensive, it's obviously not just as straightforward as, hypotension means give fluid, but, it's one of the things to think about as part of the wider picture. Skin terrier, mucous membranes, evidence of peripheral edema. Ooh, we've got some answers. Yeah, so someone said fluid status looking at JVP, edema, crackles, or more basic mucosal skin terrier. Exactly like I'm saying. Yeah, so that's pretty much the main things. Well
That's
done.
a pretty good one. Also, while you're cycling blood pressure on a patient, raise the leg end of the bed, right? And see how the blood pressure changes. Because if it's a fluid deplete patient with a sepsis, septic shock, you will see that there's a very good pickup in the blood pressure, which means that this patient would just benefit from some boluses per se. Whereas in a cardiogenic shock, again, not all of these are straightforward. You would find that there's not a lot of difference in the fluid in the leg race actually, which kind of informs you whether this patient. Again, all of your other things also helps. Dry mucous membranes and things, but again, I think I've always found the leg raise being to give a lot more objective evidence really. What do you think, Adi?
Yeah, leg raise is actually, I think, an underused tool in medicine in general. Even in the context of someone who's suddenly hypotensive, you get bleep to see them trialing a leg raise. Even whilst you get IV access or get the fluids ready, is always a good stopgap. I think it's a useful thing in terms of treatment, and also, yeah, diagnostically, it can be quite useful just to
Yeah,
sort of assess where someone's at.
exactly. Because what you don't want, like Adi mentioned, is to in a moment of panic, right? You give a 500 ml of bolus and they just get really worse, and now you need to be fixing that mess, which is really fun and very difficult to explain to a lot of people. But anyway, moving on, and I think some of the most common sources of infection in the elderly, I think 60% of your elderly population would be urine, followed by your chest, and then all the other ones, your cellulitis, your abdominal, your catheters, and stuff like that. One of the key things that are also a bit difficult to kind of discuss, and I feel a lot of us don't really do it as much because I think there's a certain amount of fear associated with, is talking about escalation with the family and the next of kin. But I think it's usually quite important to do so. Kind of explain the rationale for these things because trickle down, it has a much better hospital stay outcome, and also really good for the patient doctor relationship, because everyone keeps kicking the ball down the road, and it never really gets picked up unless the patient is really really sick. And one of the most common issues that we get is that nobody told us it was this bad, right? So always having these conversations while early is always a good thing to do. Okay, so you have an 83-year-old male care home resident who's presenting with new confusion, a respirator of 26, so tachypneic, sorry, hypertensive, and a lactate that's pending. Again, immediate steps. Quite straightforward, but what are your immediate steps?
I'll just give it a couple of minutes. But I'm sure people will hopefully be able to give us an accurate initial steps after our previous discussion. Let's see
Yeah,
what we get.
I think it's pretty much the same as what we just spoke, but this is purely for an engagement perspective. Let's see.
And we don't have any physical sweets to give out to people, but we'll give virtual sweets to the best answers. Oh, here we go. Cultures, bloods, bolus, antibiotics.
Sepsis 6. There you go. There you go. There's a reason why they hammer it into us, right? So the classic three. You take out three, you give three, right? You take out your blood cultures, you do your normal set of bloods. You want to give them IV fluids in this case, where it looks like a septic kind of picture, and you want to give them oxygen if they're required, and essentially follow that protocol, right? So thank you, whoever that was. And the next bit that we will get almost routinely is false and syncope, right? What do you mean by false? Like false and syncope is like a interchangeable, or like collapse and false, right? These are two very distinct things. When we talk about syncope, it's usually as a result of a cerebral hypoperfusion, right? So sudden loss of blood supply to the brain for a very short amount of time. Very quick results, very short as well, which is quite important. And falls in a way, syncope can result in falls. Yeah. So again, kind of when someone comes to you with falls, it's very important to kind of get a clear understanding of what they mean by that, right? Understanding if there were any mechanical causes for it. Do they have poor mobility to begin with? Did their footwear get stuck somewhere? What were they doing before, during, and after an episode is a very good way to go about these things. Things usually when it's a cardiac related is usually almost always either standing up and then just losing all, like a transient loss of consciousness, and they fall forward, right? Or fall backward in case of a postural hypotension kind of episode, where they were standing up from the chair and having that episode. So triggers such as that. Um, and I think one of the key things is red flags in these things. So, like I mentioned here, some very key red flags are exertional syncope, chest pain or palpitations, or there's a presentation of a focal neurology, and especially head injury for someone on anticoagulation, right? All of these things will have their own pathway to get kind of worked up. But the key thing is, if you have a patient with no evidence of heart disease, I think the data says like almost 96% of your patients won't have a cardiac syncope as a reason. Adi, quick check. Can you see me still?
Yep, can still see you.
Yeah, perfect. Yeah, so there's a lack of heart disease. It's very unlikely that that a patient has, a cardiac reason for a syncope. But again, you need to do your basic things like your ECG and things like that to make sure those things are true. Focal neurology, again, in cases of seizures, focal seizures, have someone coming in with a very like an epileptic disorder at an elderly age is very unlikely unless it's been established when they were young. So if someone's coming with seizures, again, doing your baseline organic causes for it is very important. Getting imaging is quite important and things like that. In the context of orthostatic hypertension, it's always looking at, again, fluid statuses, looking at what medications are they on, because you need to think these patients have been accumulating illnesses, have been accumulating medications for their entire life essentially, and all that culminates to one point, which is how they present to you, right? So having a look at all of these things, looking at the hypertensives that they're on, looking at alpha blockers that they're on, and kind of weaning them off essentially is quite important. In elderly patients, it's good to remember that tight blood pressure control is usually not recommended. We would ask them to usually, as a more than 140, more than 150 really is actually a good target to be in. And studies have shown that having a higher blood pressure always helps, because the mortality that you get from low blood pressure and low hypertension is actually much worse, right? We spoke earlier about hidden injuries from the falls, right? So falls assessment really, refractures are quite painful in a way, so it has its own local protocols really on how to manage, because they have to be referred to the pain team, integrated pain team in your local trust to manage them adequately. Nerve fractures are one of those life-changing injuries in any patient, especially in elderly patient. One third of them usually die within the year. One third of them never really recover to the baseline, and one third of them make a full recovery. But it's one of the most debilitating injuries that you can get, and missing it is even worse, right? Like I spoke to you guys earlier, patients. That's why when you do get patients who present in such cases with which is not typical of a nerve fracture, I think it is always useful to get an X-ray in the first instance and treat them with analgesia, but have a very high suspicion for a nerve fracture if the analgesia isn't helping and the mobility is really reduced. Some basic workup that we all do with most patients are the same here. You do your lying standing blood pressure, you do your ECGs, your glucose, your full blood count, and imaging if there's any tenderness or any pain, like we spoke about earlier, right? So we talk about prevention bundles. So there's a bit here. I'm just going to show you here is the RCP's fall safe care bundle. Each trust would have adapted to their own way, to their own style, but it's a basic set of things that should be done for somebody who's come in with a fall, right? What is the context of their fall? Have they had previous falls? Have they been admitted and worked up for them? Any new prescriptions? Making sure they have adequate footwear. That's why we are seeing red color socks or socks with the grippings on, really, to make sure they have adequate footing. A physiotherapy or occupational therapist review of these patients. For older and more vulnerable patients, have we done the delirium screening that we spoke about? um, um, the risk versus benefit for a lot of their medication choices that we are making, visual, auditory assessments for a lot of these people, lying, standing blood pressure checks, medication review, like you guys mentioned, and usually, a bundle for after fall as well, while it's in the hospital, is also very important to kind of rule out, right, or work out. Um, so just going back, in terms of like a quick question, what's a clue for, like, say, one clue for a subdural in a patient who's anticoagulated with a normal GCS?
It's a good question. Let's see what we get from the chat. I'll just give it another few seconds.
Not a problem.
You might well need to enlighten us on this one.
Um, so again, fluctuating behaviors, gait changes, new onset confusion, persistent headache. All of these things are clues to a subdural in these patients. But to be very honest, if this is in an actual hospital, this patient would have gotten a CT by now, right? Just the fact that they're on anticoagulation, they would have gotten a CT by now. But this is just so that you have better suspicion or an index, because the most common causes are the most common causes, aren't they? Fine. Again, so atypical. So in elderly patients, so Your typical ACS would be central crushing chest pain that radiates to your neck and arm, which is lasting for around 20 minutes or more, which is relieved with a nitrate or on rest, or not getting better with rest. In elderly patients tends to be quite atypical in the sense that they present with very non-specific epigastric pain, breathlessness, syncope, all of which can be, even the ECGs that we do on such patients tend to be quite non-diagnostic per se, which is why comparing them with their previous ECGs usually gives us a better picture, because there'll be clues for like very subtle ischemias. And it might be that you have to keep ECGing these patients till you pick up really something. On the other hand, you also get this point where, you would see your metrologist being a bit frustrated, like Adi is most of the time when I was with him. When, troponins are sent for a chest pain that we aren't convinced is a cardiac chest pain, and they come back high. And these have to be taken into context, right? Because if you have somebody with CKD, you have these troponins, kind of circulating around longer and not really removed from the circulation. So you have these raised troponins to begin with. You have demand ischemias, right? So if you look at like the fourth universal definition of an MI, they talk about type 1, type 2, and that type 2 is usually because of a mismatch between demand and feed that we give, right? So it can just be that the patient is tachycardic, probably because of fever, that they have some raised troponins to begin with, right? You can have sometimes like a PE that's causing this as well. A type 2 MI, like I just spoke about, all of these things can raise the troponins. The management tends to be the same way. Again, if there's pain, giving analgesia to kind of drive down the sympathetic drive, your oxygen if there's any hypoxia, your DAPT protocol, early cardiology input, all helps in these cases. Again, I think I've already answered that question. A non-ACS reason for troponin. So I've said CKD, I've said tachyarrhythmia. What are some other ones that can cause a raised troponin that isn't necessarily an ACS reason? Adi, you might have to look at the chat for me because I think the screen has changed and I don't want to
Yeah,
push.
yeah, that's completely fine. I'm keeping an eye out. Someone suggested sepsis as one cause.
Yeah, yeah. I think if you do have shock from sepsis and you're having a lot of the tachyarrhythmias and you're having a lot of that ischemia related to that, you can get some troponin leaks. Sure.
Something I've seen is in the context of myopericarditis, kind of leading to direct,
Yeah,
I guess, myocyte damage.
yeah, absolutely. So yeah, myopericarditis, like I said, PEs as well can cause all these features, right? So, in that context, I think being aware of the atypical features of an MI are equally important in an elderly patient. Similarly, you have an atypical stroke in older patients, right? So again, they come with, again, I think it's more so that there are certain types of strokes. So one of the most commonly screening tools that we use is FAST, right? Which is you look at if the patient can raise their arms, can they smile, can they speak, and things like that. Usually not that great for posterior strokes. So, patients who, come with diplopia or some difficulty standing and things like that, FAST usually doesn't pick those things up. They usually present with some degree of delirium, fall, some visual language changes, which, would give you a bit of a clue with the stroke. Again, imaging for these CT is pretty good, but an MRI is usually, CT angio is usually something that we go for in these patients. Um, Again, I think the stroke, you'll always have every trust will have a very good stroke team available to kind of take those referrals, and they'll be the ones really assessing about the thrombolysis thrombectomy criteria if there is one. Just coming back to the whole fast screening, what sign do you think fast misses that completely misses posterior strokes from the picture?
We'll give it 30 seconds or so.
Adi, do you want to take this one?
Oh, we've got a good response, vertigo, which I think is part of the constellation of posterior symptoms that we would see.
Yeah, yeah,
Um, I
absolutely.
was specifically thinking kind of visual changes,
Yeah,
if the occipital lobe is implicated.
yeah, diplopia, vertigo definitely are something that usually not picked up that well. So I think one key thing which I really don't see a lot of us that do are, in part of your examination, there's something known as hints exam, right? So especially when someone comes with vertigo and nystagmus, it's a very important exam to do because it helps you distinguish between vestibular causes, as in peripheral causes versus central causes, right? So that stands for head impulse, nystagmus, and test of skew. And it has a very high specificity and sensitivity and helps you address the need for a CT head in patients who come with such things. Again, in reality, when most patients will get a CT head, I think it's always good to develop these tools because hints is not something I've seen a lot. Have you seen a lot of people using hints, Adi, for patients with?
Outside of kind of specialist neuro centers or in the stroke context, very rarely.
Yeah, and I think it's something that we should be doing. I think it's the issue is every time people talk about hints, I think I always have to look up what hints actually involves because it can be a bit difficult to do. But I would highly recommend people to read up on it and always do it on patients because it just gives you so much more information, right? Moving on, polypharmacy and high risk meds. This will always be an issue in elderly patients. Like I've said, they're collecting diseases, they're collecting medications. Collecting is probably a really bad term to use, but I'm sure you guys get what I mean. It's something. It's always rationalizing these medications are always good practice. In most cases, anticholinergics that are used for incontinence or maybe as first line in depression treatment, like amitriptyline, are very notorious in these cases, are all usually one of the main culprits. Your sedatives, your opioids, your antihypertensives, hypoglycemics as well, your glycosides, your insulin, all of these things are quite important because in elderly patients, sometimes one day they might not just eat and they're still taking the 30 units or whatever. And that's usually not great, right? So always rationalizing them as part of so when most of you will be clocking such patients in, so as part of getting this whole picture, always having a rationalization of meds section on your plans is always a good thing because one, it'll help us tell which ones have been stopped and why, and it'll always help the team downstream to kind of communicate that to the discharge team, right? Which is always good. Stopping non-essential ones, checking for interaction of any medication that were recently, patients were treated for, like case one that we saw, treated in the community for an UTI and whatnot. Just making sure your P450 inhibitors, your interactors, all of these things are looked into. Making sure patients on warfarin as well. It's one of the biggest problems because when patients with warfarin are admitted, people are too scared to be like, checking their INRs and, making sure that they have doses prescribed, which means that they miss out their doses and things. It's always a good question to see why they're put on warfarin, obviously, and seeing if DOAC makes more sense in such patients. Um, Again, I think one a really good resource to use is something called Stop Start, which is by the Geriatric Society. It's a PDF document that you can go through that tells you things like cardiovascular disease, cardiovascular medications, your hypertensive medications, your stroke related medications, your diabetic medications, what make most sense to be stopped or weaned in elderly populations. It's a very good and useful documentation to go through while you're clocking these patients in, right? There is also a really good, useful website called e-prognosis. I should have actually put on a slide here. Have you heard of that, Adi?
I don't actually think I have.
It's a very helpful e-prognosis. So if you type in e-prognosis on a website, on the search bar, and go to time to benefit section, so it tells you all the medications and how many years it takes for to see an actual benefit from it, right? So if you have an 80 or a 90 year old on an insulin, you need strict glucose control for years to kind of like benefit from that, right? But in an 80 or a 90-year old, you probably don't need strict glucose control. That's why for elderly patients, we prefer something like 11 to 14 BM control rather than something way stricter, right? So, rational like that go a long way. So I think going through this document, very helpful. Going through e-prognosis and time to benefit within e-prognosis is a really good resource to use and to look at the rationalization of all these medications. Again, goes really well, right? AKI and dehydration, almost always a thing. If you have someone coming in, so pre-renal, renal, post-renal, right? So pre-renal are almost always because of a kind of like a plumbing issue, in the sense either there is a clot or there's not enough blood or there's not enough fluids, right? These are what are called. So dehydration, like vomiting, burns, diarrhea, medications that are kind of exacerbating all of these things. Like, so risk factors I mentioned: ACE, ARBs, diuretics, sepsis, dehydration, all of these things kind of play a factor, right? So yes, pre-renal is a very common cause. The other most common is, especially if you have, it's in all of these patients, again, we talk about baseline noise, right? So they will always have like raised creatinuria and EGFR that's low. It's really important, if you can, is to plot and see, different systems have different ways. Sometimes your system will be able to tell you a graph of what their levels are, and to see what is their baseline and what is it now, right? Because if you have a very acutely high creatinuria jumping up, you need to ask, is this a post renal cause, right? In elderly patients, most of the time it tends to be retention, maybe a BPH related or acute retention that's holding up and causing a very high this thing. Did these patients have an a urinary ureteric stone, right? Strictures, all of these things, again, a post-renal cause for an acute jump. I mean, it'll have its own working up to do. Renal causes tends to be quite, what do you say, quite rare, not rare. I think incidence tends to be lower compared to your post-renal and pre-renal. I think diagnosing it is also a lot easier in terms of the pre-renal and post-renal. Renal causes, so these are all your drug-induced ones, are a bit tricky to kind of figure out. But the most key indicators are the pre-renal ones that you should be knowing. So checking retention, like I said, is a very, very important thing to do. There's no excuse for not picking up bladder retentions, right? And while you're treating them, making sure you give your cautious fluids, you making sure you're not giving any nephrotoxics on top of your AKI patients, which happens quite a lot. I think we tend to get very uh, machine like in these cases, which is why we should be very aware of these things. And sick day rules usually, so if these patients are on ACE, ARBs, or diuretics, making a sensible plan to stop these while or suspend these while they're being treated for AKI makes a lot of sense, right? And just making sure in somebody with a heart failure background that you're doing your daily weights and input output and making sure they're not retaining or getting worse, because the last thing you want to do is miss that for 4 or 5 days, an impending worsening AKI, and you just pick it when they're completely cooked, right? not a thing you should be doing, right? Again, in these cases, like we spoke about, making sure that you don't like overload these is also a tricky thing to do, so be aware, right? The last bit of things that I wanted to really talk about was the CFS and the news too, right? So I spoke to you guys about the Rockwood scoring and stuff. One of the key things that I think starting doctors that we face is having difficult conversations because we feel like we're not senior enough to have those. In frailty, if you do get these rotation or you do come across, practice it. Practice talking to them. And I understand it's difficult when they're acutely unwell. It might seem like we are giving up on them, but it's about how you communicate this across, right? um, Explaining frailty to them about how their new baseline is probably what they're looking at. There is no recovery from this, and talking about different levels of resuscitation, why CPR doesn't make sense. And actually, this does not mean that we are not going to treat them. In fact, we're going to treat them as much as possible. But we usually make this decision or we make this call when we think whatever we're giving them is not working, and it comes with a lot of practice. And but I would heavily encourage you guys to start doing it, because if you don't start doing it now, you're going to find that it gets more difficult as you get more senior, because people are going to be expecting you to have that conversation. And it's always helpful to get these escalation levels put in place, so that it's always helpful for downstream teams to make a call as well. Okay. And I'm sure most of you are aware of the news, this thing, the new scoring. It's something because we get a lot of information fatigue looking at this, because something we look at this all the time, but it's extremely helpful to know what what way they're heading, right? And it's always good to be aware of the news criteria for triggering met call and whatnot, or medically alert, and knowing what your local guidelines levels of escalation are in these cases, excuse me, are very helpful, right? Um, so I think that's the end of the session, and I think this key summary that I want you to understand is that there's a lot of high baseline noise in these patients. So knowing what their baseline to begin with is quite important. Atypical is that typical, and that's really important. Not being, not understanding, not really assigning, or someone's 89, let's not do anything for them. Please don't have that approach in these patients, right? Not all frail people are old, not all old people are frail. We should always encourage to treat what is treatable and not really give up on them. Communication is very key to take care of these people. Treat the patient, not the number, right? Even if the numbers are looking good and the patient doesn't look great, you should be really working in and seeing what's going on. Reviewing their meds, and also interacting with them as much as possible to understand what their baseline is quite important. Yeah. Some of the resources that we used in the conversation today was your 480 screen, your Rockwood score. You can use your local, guidelines, and the syncopal pathways and fall pathways are very helpful in each of your trusts actually, and see what they're like. Some of the references that we used through the whole thing. And I believe this is where you get your feedback and certificates. Any questions, comments, compliments?
Lots of compliments. That was an excellent talk by my good friend. Yeah, no, I think just to kind of underscore everything that Gopinath's been saying throughout the talk, it's so important to kind of approach these patients slightly differently to how you would your typical kind of otherwise well 30 or 40-year-old. They're often a lot more complex and there's a lot more nuance to how they present. So, as you said on your first slide, kind of seeing the signal and the noise is really important, and being able to discern between all the various aspects of the presentation is a skill that we all learn throughout our careers, and it's always kind of an ongoing thing. Exactly. Yeah. Um, but yeah, we'll leave the chat open just for a few minutes, just in terms of questions. Getting some compliments. Someone says it was really good talk. Learned a lot. Thank you very much. Which is very much true. Um, Also very aware that Gopi had a big weekend, but has still made the time despite being unwell today as well to come and give us his talk. So very grateful for his time in that regard. We'll just leave the chat open for a couple of minutes. And of course, if anyone has any questions, you can always get in touch with the Wider Minded Leap team on our website. There is a link for questions and kind of inquiries. I'm always happy to field any questions that way. If anyone is interested in a career in geriatrics or anything along those lines, also to get in touch. Happy to have a chat. But yeah, I think we can probably leave it at that. Thanks a lot, Gopi, for taking the time this evening. And thanks to everyone for attending. Our next talk will be on the 20th of October, given by me again. It won't be quite as high quality as this excellent talk today, but it'll be talking about dementia, cognitive impairment, and kind of how to discern and distinguish between those. And I think it's quite useful. And that'll be, for now, the last talk in this series. But everything is available on YouTube to watch on catch-up content. Yeah, thanks everyone for attending, and see you next time.